Well, hello. My name is David Songyong Kang from EYEREUM Eye Clinic in Seoul, Korea. And yes, today we are going to perform. I am most honored to be able to perform this very special PresbyMAX case to none other than a very dear friend and colleague, Dr. Kishore Pradhan. This all began when I received a very unexpected phone call.
Hi, David. How have you been? How is Korea? How are you doing? Recently, I've been really struggling with these near vision, and I want you to perform PresbyMAX surgery on my cornea. I think you'd be the right person to do it for me. Can you do that for me? It's a request.
Of course, Kishore, I'll be honored. Let's get you seeing your best. When's a good time for you to come to Korea? Dr. Pradhan is a renowned specialist in refractive surgery. But today, he's not here as a doctor, but as a patient. This time, he's on the other side of the laser, the patient side. Okay, give me a couple of blinks. Okay, how are you feeling?
I'm feeling great.
It went just great, okay?
Yeah.
The cap, the flap, it just fit everything. Can you see your watch? Tell me what time it is.
It's like, wow, amazing.
You can see the hands ticking?
Yes, I can see the seconds ticking.
Mm-hmm. Even in a room with low contrast,
Yes,
right?
yes, it's so amazing. I think my patients feel all the same like this.
Yeah.
It's
so much
fast in
change.
5 minutes, my life has changed. Hi, I'm Dr. Kishore Pradhan, and I'm a refractive surgeon, and I practice in Kathmandu in Nepal. And now I've treated more than about 20,000 patients for refractive surgery. I've done about 50,000 cataract surgeries now. And I own a clinic right in the center of Kathmandu. It's called the Matrika Eye Center, and I'm the medical director in Matrika Eye Center. So now, when it comes to treating presbyopia, I treat most of my patients with PresbyMAX nowadays. At the beginning, we're just treating them monofocals. Making them monocular treatments, like treating them with LASIK, doing a hyperopic treatment. So before considering PresbyMAX for myself, I reviewed and looked into all the other options, or just a simple hyperopic treatment or intraocular lens exchanges. And I think the right choice for me would be a PresbyMAX. The monovisions the advantage of PresbyMAX, I think, is the patient has the better distant vision, and the depth of perception is better, I think. Most of my patients say that. And I wouldn't consider monovision for myself. It's just simple, making one eye clear for near, but my depth of perception and my quality of vision would definitely not be as good as what my PresbyMAX patients tell me about. And even the intermediate and the distant visions are also much better than monovisions. Going into the eye would always be a last solution for me because I don't have a cataract right now. So I still have my accommodation without disrupting my accommodation. And then I think I still am very young right now. I'm 53, so I could have a posterior capsular opacification where I might need a YAG laser capsulotomy. So I think I want to stay on the surface of the cornea. And in the end, I chose PresbyMAX for myself.
Well, from past experience, I knew Kishore was presbyopic, not just because of his age, but he had huge fonts on his handphone. And obviously he was not myopic, since if he was, he wouldn't need huge fonts. And on proper examinations, we found about a quarter diopter of hyperopia with very little corneal toricity. Both corneas were white-to-whites of 11.5 and good pachymetry around 550 microns. So very good to have a surgical intervention. However, it's really tricky, it always is, to intervene on an almost emmetropic eye. We decided to preserve the right eye, the dominant eye, and operate only for the increased range of focus on his non-dominant left eye. Oh, that's a very good question. It's always a big honor to be chosen from one of your own, so to speak. I think this is the same for everyone in a profession. But as a surgeon, to be picked by a colleague to have surgery on a fellow colleague was something exhilarating, and I am most honored. Kishore is a 53-year-old male professional, very active in sports and leisure. I would not recommend a lens-based procedure to an emmetropic eye without the presence of a cataract. Refractive lens exchange does have its circumstance, but not in this regard. Number two, the other options are corneal-based, and obviously monovision with more than a diopter and a half of anisometropia is going to produce binocular cross blur. And we tested for this, and he did not adapt to it. And of course, PresbyMAX only utilizes about half of that, 0.89 diopters of micro-monovision plus negative spherical aberration to take up that slack in near vision. It was just perfect for Dr. Kishore. Well, the most important essential thing was to properly assess Kishore's refractive status. Because in mild hyperopes, we find after cyclopentolate refraction, occult hyperopia that is hidden down there somewhere. But evidently, in this case, it was not. Luckily enough for Dr. Kishore and for me, we could go on with the procedure safely. Number one, active professionals in their 40s and 50s with presbyopia who are not yet ready for lens-based surgery. Number two, even those people with previous laser vision correction who are not candidates for lens-based solutions and whose previous surgery has invoked positive spherical aberration as well as coma due to previous decentrations in very small optical zones are actually a great candidate for corneal wavefront-guided PresbyMAX surgery because we will be addressing not just the presbyopia, but the corneal high-order aberrations inherent in that kind of cornea. Number three, even those pseudo-phakic patients with monocular IOL implantations are great candidates. So there is a big spectrum of patients out there who could be great candidates for PresbyMAX. So it's basically a very normal cornea. Right?
Yeah.
Okay. Good pachymetry, 547, minimal pachymetry, whites 11.54. That's terrific. Okay, let's just go straight to treatment. But you do have a lot of positive spherical aberration for a virgin cornea and inferior coma, right? And we are going to address that at the same time during surgery. So let's go to the OLK cam. And because of that positive spherical aberration and the inferior coma, you're probably going to get an aberration-free profile that ablates more than the full corneal wavefront guide because it's a hyperopic profile, right? So I propose that we decrease the amount of ad by about 1/10 of a diopter, but instead, by an increase in correction of hyperopia, sphere correction by about 1/8 of a diopter. Okay?
Okay.
All right? And we're going to go to huge 7.5 millimeter optical zones for a total ablation of around 8.4 millimeters. So I would suggest a 130 cap of 9 to 9.3 millimeters.
Yes.
Okay? You like that?
Yeah, I like that.
Then let's go for it.
Yeah.
Okay.
Yeah.
Well, presbyopia is the natural process of aging. The denaturation of our crystalline lens proteins makes it less flexible, and the progressive weakening of the crystalline lens zonules also aid in the progress of presbyopia. Now, the ideal solution for a presbyopic solution would be to restore the natural accommodation process of our crystalline lens. But unfortunately, this has not yet proven to be possible. So most presbyopia correcting methods utilize what we call pseudo-accommodation, utilizing the neural adaptation capacity of our visual cortex. The introduction of monovision to around -2.25 to -1.5 was unacceptable to many individuals, this amount of anisometropia for monovision would produce too much cross blur for the visual cortex to process. And hence the concept of micro-monovision, where the difference in the dominant and the non-dominant eyes is less than 1 sphere diopter, was born. This aided less cross blur and was much more accepted by the human visual cortex. But 0.88 or 0.9 diopters of myopia was not enough for the near vision tasks to be facilitated. And that's why at Schwind, they recruited negative spherical aberration on the visual center, the visual axis, the corneal vertex, to increase the range of focus. Well, PresbyMAX utilizes less anisometropia and is much more accepted by the human visual cortex. Number 2, it utilizes negative spherical aberration on the visual axis, on the corneal vertex itself, to increase the range of focus. So less anisometropia and more range of focus are the two definite advantages, while the dominant eye is giving you great distance vision. In fact, 2 years ago, in 2023, we published in the Journal of Cataract and Refractive Surgery that the non-dominant eye, the near eye, was seeing unaided far vision. 89% of our patients were seeing better than 20/50. 78% were seeing better than 20/40, which is what Kishore is seeing on post-op day 1. And even 34% with the near eye was seeing better than 20/32. And 100% of this near eye was seeing J2, while a whopping 83% of these eyes, of these patients, were seeing J1. Well, actually, there were two aspects. Number 1, his white to white was 11.54, and I wanted to make a big a flap as possible because we wanted the biggest optical zone to produce a lasting negative spherical aberration induction on the visual axis on the corneal vertex. And I opted for a 9.0 millimeter flap over a 9.3 flap because his limbal junctions in the superior cornea had slight pannus or conjunctivalization. And the 9 millimeter fitted just great. Number 2, his virgin left cornea had previous positive spherical aberration coupled with slight inferior coma. Now that positive spherical aberration on a hyperopic ablation is going to be ablated a little bit more because of the nature of the hyperopic ablation. And because of that, the aberration-free profile was actually ablating more than the full corneal wavefront-guided profile. So we decided to increase his hyperopic sphere to be corrected, but instead to take up that slag, decrease his ad by about 1/10 of a diopter from 1.75 diopters to plus 1.65, and it worked like a charm. PresbyMAX provides great binocular vision at all distances without compromising safety, visual quality, nor stereopsis. It outperforms multifocal lenses, refractive lens exchange, by preserving our own crystalline lens. PresbyMAX is great. You feeling good?
Yeah.
Okay, should we check your vision now?
Yes.
All right.
Absolutely.
Okay, let's check the far vision for the near eye. Okay, so please cover your right eye. Okay, can you make this out?
Yes.
Can you please read the optotypes?
NEHZO.
Very good. Even this?
Yes. And
And I bet this is difficult to make out.
yes, a little bit.
Okay.
But I still can, a little bit, yeah.
Okay, you're 10/20. Well done. Okay, me that. But this time, let's do it binocular.
Binocular.
Okay. And you're reading up to here.
Yes. SONAR.
And this.
And this is KZEN. Oh, yeah.
Okay, I want you to take your time. Can you read this?
K AENZO. Yeah.
That's 20/16.
Yeah.
All right.
Yeah.
Thank you.
Amazing.
Okay. Now, bilateral binocular near vision summation. Okay. Can you read J3?
Yes, 462-830-973.
Can you read J2?
576-214-305.
That quick.
Yeah.
Even J1?
931-749-862.
That's amazing.
Yeah.
But I bet you won't be able to read that.
That's easy peasy. 616-254-237.
You can read that?
Yes. Amazing. Oh,
I can't read that.
Yeah, I can't.
Well, congratulations.
Thank you, yeah.
Okay, now let's check out the postal corneas, okay? Section images first. From the section images of the MS39, remember we made a 9mm flap, and this is a vertical cut starting from the corneal conjunctival margin, right there, you can see it, right? Remember it was a 9mm 130 micron flap, bang on the dot, 130, measure again here at 128. Great, right?
Yep.
And we're gonna compare the pre and post wavefronts. Negative spherical aberration with slight decrease in coma. Drift from positive spherical aberration to negative spherical aberration. And that's what's giving you the great vision. So congratulations.
Thank you.
Again,
You're the best. I've done hundreds and thousands of treatments, but when it comes to me having treatment on the recipient side as a patient, I knew exactly what to expect, but it was so super quick and calm and so easy, and I was so confident on my surgeon. The protocol's a little different, but it was the best. I think it went in very, very smoothly. We went through my ocular dominance first, and then we went through the scans and looking into the asphericity of my cornea. And then a great planning was done, looking into all the aberrations, and then fine-tuning of my microvision stuff that was done for me, and then the amount of spherical aberrations induced and planned was amazing. I really appreciate how the software allows you to fine-tune the micro-monovision and the spherical aberration inductions. Amazing. I feel amazed. I'm amazingly well. So what I was expecting was a little bit of pain during the day of surgery, but it was absolutely painless, a little blurry on the day of surgery. But when I woke up in the morning, my vision had already blended, and then my distant vision was great, my near vision was great, and I was on the phone all the time because my phone was never so clear. My watch, I could read the dates. I was on the, I was like running around and jumping around, in my hotel. I could do everything. Like I could read the medicine bottles, and I was so happy and so thrilled. I think this is the best decision I've taken to do a PresbyMAX on myself. I think I'm going to have a great life for another 10 years now. Don't need glasses anymore. So, note to our colleagues, like my refractive surgeon fellows, I think they should all learn how to do this. Not very difficult. And imagine, I've done it for myself, and I know what my happy patients were actually telling me, and I've done hundreds already, and after I've done it for myself, I know I'm going to do thousands more, definitely. And I recommend to all my colleagues to at least learn it and try it. It's an amazing procedure.
well, PresbyMAX integrates beautifully into a pre-existing refractive suite with the MRS if you're practicing LASIK or SmartSurf Transpia Kang. In fact, the user interface is so intuitive and is so not different from the user interface I would be using for non-presbyopic refractive surgery. If you're aware of the centration techniques, ocular dominance, and corneal spherical aberration, then it is just a breeze. In fact, great patient satisfaction is what drives doctors' confidence. Oh yes, active professionals in their 40s and 50s who are just not yet ready for a lens-based procedure and who are waiting for the next best lens to come out. These are great candidates. But even better candidates are those people who've had previous laser vision correction earlier in their life, maybe in their 20s and 30s, who have had slight decentrations very small optical zones and who now have corneal coma and much avoidable positive spherical aberration. PresbyMAX corneal wavefront guided customized can not only correct these eyes' presbyopia, but also at the same time gets rid of the coma, the spherical aberration, resulting in greater visual quality. Moreover, those pseudophakic patients with monofocals can also benefit from a PresbyMAX procedure, which is much less invasive than a multifocal IOL exchange. PresbyMAX is a highly versatile procedure that can be performed as LASIK or transepithelial PLK and highly customized to the individual needs of that cornea, especially the ADPA and the amount of spherical aberration that needs to be created for that range of focus to every individual's different needs. Monocular PresbyMAX, which I favor above all the other former iterations, gives good interocular rivalry, great distance vision with the dominant eye, and great near and intermediate distance, but blended together in the intermediate range. Moreover, it can even be fine-tuned very easily, but also even reversed with a Presby reversal procedure. Imagine the benefits of a refractive surgery procedure, a presbyopic refractive surgery procedure that can be reversed like that.
I also thank Dr. David Kang and this whole team and the EYEREUM Clinic. They've been absolutely hospitable to me, and I had a wonderful experience, and best of luck for everything. Dr. David, thank you so much.
Thank you very much for the interview.
Thank you, Dr. David. Thank you for everything. You've got a great setup here and a great team. I really enjoy it. I couldn't have been in better hands. You're the best. I really thank you so much.
Thank you.